I'm Salma Shivji. I'm one of the hematologists in Calgary. I've actually had the great privilege of training under two of our speakers we have today within residency and fellowship. I will ask them to introduce themselves. We do have Dr. Cynthia Wu as well as Dr. Marc Carrier. I might as well start with you, Dr. Wu, if you can introduce yourself.
Sure. Hello, my name is Cynthia Wu. I'm one of the hematologists. I work in Edmonton, Alberta at the University of Alberta Hospital. I have a special interest in thrombosis, particularly cancer-associated thrombosis, and I did a few years ago start up our first cancer-associated thrombosis clinic in Edmonton. It's growing out of control now, so I'm very happy that we have a good group of people in Canada to rely on for all these updates in treatment.
And then Dr. Marc Carrier, if you want to introduce yourself.
Thank you, Dr. Shivji. I'm Marc Carrier. I'm one of the hematologists in Ottawa at the University of Ottawa, at the Ottawa Hospital. I do venous thrombosis for a living, and just like Dr. Wu, I really have a particular interest in the context of cancer-associated thrombosis.
Perfect. And so the purpose, of course, for today is to discuss the new cancer-associated thrombosis algorithm that was through the Canadian expert consensus. I'll start off asking you a question, Dr. Wu. Could you please explain the motivation to revise the 2018 algorithm?
Sure. I think we can all agree that cancer-associated thrombosis is common and important, and the cancer patients are very complex, including their cancer types and their treatments. So the management of thrombosis is really not very straightforward compared to, say, for example, the more benign population. When the DOACs first came out, or the direct oral anticoagulants first came out, they're very appealing alternatives because, of course, if they don't require INR monitoring like warfarin, they're cheaper and they're oral alternatives, so like white heparin. So I think people started to use these drugs very rapidly, and the uptick, even in cancer patients, started prior to prospective and randomized trial data coming out. So the 2018 algorithm, although we knew that we did not have a lot of data at that point, came out as a more rapid response to that growing need for guidance in the use of DOACs in cancer-associated thrombosis. And then we really only had one large randomized trial with edoxaban and one smaller pilot randomized trial with rivaroxaban. And so there's still a lot of gaps in the knowledge and obviously a void in apixaban at that point when we didn't have data. So in 2021, we felt that now that we had one data for apixaban as well as a few extra trials in the other drugs, and additionally 3 more years of just reflection, clinical and practical experience with these DOACs, we thought that updating these guidelines would be very important to place into context how we use them in cancer.
Oh, that's great. And so the next question I might as well pose this to you, Dr. Carrier. For this guideline and the algorithm, which healthcare group or groups is it most directed towards?
It's a great question, Dr. Shivji. We really tried to be inclusive because venous thrombosis is often an orphaned disease and taken care by sometimes general internists, sometimes hematologists, sometimes respirologists, and it's different in every different centers. And especially in the context of cancer-associated thrombosis, sometimes this will be dealt with by general internal medicine or a thrombosis specialist, but sometimes also by a medical oncologist, a general practitioner of oncology. Sometimes nurses practitioners will help in the management of cancer-associated thrombosis. And as Dr. Wu mentioned, this is a complex patient population, so we really tried to provide some guidance to help tailor anticoagulation to different healthcare providers, independent if they're any clinicians, really, independent if they're nurses, pharmacists, or doctors, if they're general practitioners or specialists, really trying to be inclusive, trying to provide some guidance very broadly to clinicians in Canada.
Thank you for that answer. And kind of springboarding on that, and I'll direct this back to Dr. Wu, what are the most important changes that the group made to the algorithm, and why are they important?
Good question. So obviously a lot of data and information. I definitely recommend people read through it to get a little bit more of the information. I can start by saying that we did, of course, reinforce some of the more well-known things or more well-accepted things, such as use of low molecular weight heparin over vitamin K antagonists, and the fact that DOACs are now emerging as potentially an equal standard to low molecular weight heparin, although of course with a little bit of discussion. We did reinforce that incidental VTEs, while maybe not as significant as symptomatically diagnosed VTEs, still carry considerable recurrence risk and should still be evaluated for therapeutic anticoagulation. And the incidental VTEs were very well represented in the direct oral anticoagulant trials. So I think worthwhile to just remember there are some things that are still common. We expanded a few of the sections, which may not have changed dramatically what we had recommended in 2018, but worthwhile to read the updated information, for example, for the secondary prevention or long-term treatment of cancer-associated thrombosis, information on how to deal with intracranial lesion patients or upper extremity DVT. So those sections are possibly a little bit longer than they were last time. I think in terms of updates or new things that we added compared to last time or changed, of course, all of the recommendations related to apixaban have now been additionally added in. And really the guidance statements are on roughly a similar level of recommendation to rivaroxaban and edoxaban, but it gives us more options now, so worthwhile to take a look. We have highlighted once again the high-risk bleeding tumor types, which include the intraluminal GI and GU tumors, and focusing on evaluating bleeding risk for patients, because even with apixaban's data, we unfortunately are still seeing higher rates of clinically relevant non-major bleeding in the direct oral anticoagulants compared to low molecular weight heparin. We've also highlighted a specific site of bleeding that was not mentioned at all in 2018, and that's abnormal uterine bleeding. And while I feel embarrassed to say this as a woman, that we have not really ever included this in probably the vast majority of VTE trials and guidelines, it's very important and happens to a large proportion of women. And so we put in a little bit of additional information about recognizing it, and also initiation of appropriate management, including gynecologic review, hormone therapy as appropriate, tranexamic acid, iron replacement. So something to think about. One of the changes in the high-risk bleeding groups that we included was related to patients with moderate renal failure. So we were a little bit more cautious about recommending direct oral anticoagulants in this group in 2018, mainly due to the lack of data. But as we started to get more confidence and as the apixaban data start to come out, both in benign and cancer populations, I think we're gaining a bit more confidence to use the direct oral anticoagulants, still with caution, but at least not as an inferior or a less good option compared to low molecular weight heparin. So we amended the guidelines in 2021 to just refer mainly to the product monograph and make sure there's no other exclusions, but to consider DOACs in these populations when appropriate. We also relaxed a little bit on the weight restrictions. Weight is an ongoing discussion even outside of cancer, but with the last few years of mostly post-marketing data, some retrospective cohorts, population data in admittedly the benign population, we realized that maybe the previous guidelines are a bit restrictive in terms of avoiding DOACs in the very high body weight patients. So we've relaxed the guideline a little bit. It should still be a discussion with the patient, acknowledging that the data is still lacking, but a bit more confidence using them in the higher body weight patients. And we've maintained for the lower body weight patients, since they are at higher risk of bleeding on any anticoagulant, that may be preference to using a adjustable medication like low molecular weight heparin, or of all the direct anticoagulants, edoxaban does have some built-in dose reductions even in the acute phase of VTE for various parameters, including weight, and so that one could be considered as well too. I know it's really a lot, but if I missed anything, I'm happy if Dr. Carrier wants to jump in and add anything.
No, I think you did a fantastic job, Dr. Wu. It was really, we added a lot of data and solidifying really the previous guidance document that we had. And what comes to mind, as you mentioned, was really we have a bit more data with intracranial disease, so metastatic brain lesions, for example, primary brain tumor. So we were able to add that. And there's quite a bit of drug-to-drug interaction. I say quite a bit. We have more information on drug-to-drug interaction, and a lot of the data is coming from Dr. Sufei Wang from Ottawa as well. So we were able to add, there's really a growing community in cancer-associated thrombosis research in Canada, so we were able to highlight all the pieces of data that are important to incorporate into clinical practice. So it was a lot of fun to do.
Thank you so much for those answers. It's very comprehensive. You probably already touched on this, but I can ask this to you, Dr. Carrier. More specifically, how do you think the changes will impact clinical practice?
I think it will really provide a framework to clinicians that are not necessarily, so it's easy for all of us to talk about cancer-associated thrombosis because this is what we do for a living, right? We see cases every day. But I think for clinicians that are seeing cancer-associated thrombosis occasionally, it will really provide a framework on what are the different steps or what to think about when you make a decision or when you decide to tailor anticoagulation for a specific patient. And I had a lot of feedback from the 2018 algorithm from a number of colleagues around the world. They really used it. Like, our initial idea was to develop it to help, Canadian practice, but it was incorporated into a lot of other national societies, and people have used our algorithm to, tailor it based on their national practice, right? So I think it will hopefully have an impact at a national level, but hopefully too will be influencing other national societies to have algorithms and help clinicians to manage these patients.
That's really amazing to hear. It's meant to be Canadian, but really is more international. And with that, because we've talked a lot about the guidances here, I'm just wondering for both of you if there are any additional thoughts that you want to pass on to the viewers today.
Sure. We've learned a lot more, and I think we're all more comfortable using all of the anticoagulants in the last few years. But of course, cancer-associated thrombosis is still very complicated. There's no one-size-fits-all approach. I wish there were, but then I'd be out of a job. So the data do support the direct anticoagulants in most patients, and I think we should start to feel more and more comfortable about this. But unfortunately, they don't replace completely the need for low molecular weight heparin. So there still requires us to really look into the patient and try to individualize our approaches. High-risk bleeding patients, those drug-drug interactions, as mentioned, significant problems with the GI tract and absorption, any situation we might want an adjustable medication or something just has more clinical practice experience like the traditional treatments might offer. But really with close monitoring, I think the end of our algorithm really is very helpful, where it loops back into the beginning with a little arrow that says we should just be reassessing our patients regularly. So the patients might change, the cancer treatment might change, our knowledge might change. It's always good to reassess patients and then educate our patients so they know what to look out for and when to come back to the hospital to get evaluated. And I think just having a greater variety of anticoagulant options just benefits the cancer patients with thrombosis. And I'm pretty excited that we live in this day and age with new drugs.
Absolutely. It's just more tools in our toolbox for the management of cancer-associated thrombosis. And, management used to be reasonably simple 4 years ago, where everybody was getting low molecular weight heparin. Now we have more tools, but it also complicates the clinical picture and how do you make the right decision for the patient, which is leading to personalized medicine. So I think my last thought would be to really go through the algorithm, not really to give you a recommendation, but making you think about what you need to consider when you make a treatment decision for these patients.
Thank you both so much. That was very, very insightful. And, a lot of people, I think with that, we're probably done. Thank you again so much for joining us.
Thank you, Dr. Shivji.